Friends, it's a very less hard thing, and it is useful in much of the complicated cases. We have lost the techniques of composite tissue transfers. A tissue that has its own blood supply, and that is vascular bone grafts in deadly trauma that can lead to amputations, or non-unions that are occurring even after Elizaros, compression with Elizaros and all that. So, we will see the efficacy in just 5 to 10 minutes. There are multiple uses of these vascular tissues, but I have a few examples. A tibial condyle that is totally shattered, and it went to some ICU that is ambulance driven. Some surgeon done a thing like this. The tibial condyle is overhanging and then referred the patient to higher center. At this situation, the problems are the case is also already infected, the suture line is blackening from its nearby areas, and they will give away anytime. Second thing, this is a weak fixation. It cannot run till the healing of this condyle. Third thing, if you know that the supply of a tibial condyle comes from metaphyseal-diaphyseal area, and there is no, it is totally void and gone. So I think this, even before healing, this case will go into avian or osteonecrosis of tibial condyle. So, what are the options in this such like cases? Pranav Shah sir and Prakash Abhin sir both are sitting aside. What can be option for such a case?
Yes. So, see, first and the foremost thing is that the fracture and everything else is a secondary thing. Prevention of infection and getting proper soft tissue healing is the primary thing. So, in my understanding, a bridging fixator and probably an antibiotic cement block in that void, and then whatever management for the soft tissues, allow things to settle down, and then you can consider. There are a lot of issues apart from the fracture. Entire lateral side, your meniscus, your these collaterals, your ACL, all these seem to have been damaged. So, the reconstruction is going to be a long path.
Sir, when we, there is a slide ahead, but I will say that this patient are going to live with lateral instability. There is no way, because a surgeon has debrided everything. He has debrided peroneal, everything. He has debrided lateral meniscus, everything he has debrided out.
So, know whether it was debrided or it was due to injury. How can you say that the original surgeon has debrided everything? It may be because of injury.
Maybe because of trauma, but I had some pictures of it, probably not brought here. It was a very small scar trauma at the stage of the patient got admitted. It was open. Invariably it was open, but the scar was very less. Probably it may have injured by bone spikes that has been exploded out because of heavy accident.
Looking to the X-ray, it seems that the extensive soft tissue injury was there at the time of injury, it was not by the surgeon who treated.
Yes, maybe possibly. So at this situation, what we plan, as I am well versed with microsurgery, The thing I thought was, I am also doing Elizaro's fixations and everything. Thing I was thought that first comes any difficult case in my mind, the answer is Elizaro. So I found that I would not able to restore the blood supply of this condyle. One thing was problem with Elizaro. Second thing was it is difficult to give any compression to this condyle because there are no wires possible in a proximal condyle. So I seen toward the microsurgery. I planned microvascular fibular bone graft. That means fibula is not alone. It's with blood supply. It's two pedals for a coverage and custom made plates. Those have a screws of 1.5 and that can catch up the condyle. So we have planned that, but we actually same time I have to think that what we will do if we will not able to isolate the tissues we planned. It's a very difficult thing. Isolate the fibula and with its pedals and then something else to cover up because it needs if we will plate it then we will need a huge coverage because coverage is already short. So additional advantage of supramalleolar flap has been taken. Already these things are very well known to microsurgery people who every day do it. The supramalleolar flap with fibula has hardly done in India by a few microsurgeons where cancer defect is longer and at two places where they need to cover the two places. One is with fibular pedicle and second with supramalleolar flap. So as I have done, heard a case from onco people at some point of a time, I thought to apply that to this case. Now, what happened? Intraoperatively, obviously, there was a frank pass, and while isolating, we cut both the pedicles of the fibula, and we were not able to isolate any pedicle from the fibula. Just we were able to isolate just one supramalleolar flap with this in this case. So, supramalleolar flap comes already obviously. That has been, this flap had been isolated from the fibula. You can see the artery of a supramalleolar flap that is going into the peroneal artery. And then the vascular fibula was isolated. I can clear this picture by this picture. This is the supramalleolar flap. Now, if I have to rotate this fibula in a vascular fashion at the tibial condyle, I need to remove certain segment of fibula and that I had removed. So the pedicle continues still above. And this was rotated and it was, a thing was when we lost the pedals of the fibula, how we will fix the plates? That was the question because it was a very short test. If we will fix, then it will come out in a few days. Or there is a rule in microsurgery, if you are tight, any flap, a little bit even it will fail. So you will see many surgeons extending the indications of interpolational and rotational flap. That should not be done. If you are uncomfortable, your coverage is short, go for free flaps. Or ask him to, or just beg a help to microsurgeon who is doing free flaps. Don't allow anyone to extend the indications of flap on the behalf of that tight tissues. It will 100% get failed. And same will happen with this isolated tissues. If I would rely on this skin petals that I hadn't not isolated, the plate will come out on a second day. So what we done now we had a lost option of fixation and we were intraoperatively also thinking now what we should do. Should I ambute? Should I go to direct arthrodesis? Leave it. The medial condyle will unite with upper and patient will get a stiff knee, but it will be ambulatory patient. So after thinking, we came to this scenario, I fixed that vascular fibula with just KYS. And we ended like a same surgeon, same like previous surgeon. It was a weak fixation. The coverage was also deficient even after using KYS because there is an extensive infection and extensive tissue loss because of the previous suture line. If we will continue with the same gangrenous skin margins that are not going to survive, that is not an answer. So there is also possibility of infection same way because we have not given a proper coverage. Actually, the actual picture was initial picture. This one was the picture. We had to leave certain tissues open because if we tighten or make it a tight, everything will fail. That was for sure. So, at the person who knows microsurgery, it was okay on my side because I believe that vascular bone grafts unite in a fraction of days. When the tissue has its own blood supply, it will unite in a fraction of days. Like maximum 45 days, we see union in vascular bone grafts. Second thing, it can be with a weaker fixation. Much of orthopedic principles doesn't, they are not staunch like we used to think in a comminuted fractures or like that. Once you have added vascular bone graft anywhere, its own blood supply, it swells up that cortical tissue very fast. And the soft tissue that were deficient will heal up eventually. That was my principle and it happened. Actually, I have a habit of putting my cases in WhatsApp groups. Each and level person immediately was telling that this will fail in some leg of a time. Let it be 7 days or 10 days, it will everything come out. So I was also feared of that, but for a certain time period, I fixed it with external brushing also. And at the time of 1 month, this X-ray picture was, even I was fearing too much that I have taken something like a huge amount from the patient and would it recover or not. So I started weight bearing the patient at the end of 1 month. So when I post this picture, people told me just weight bear on an affected limb. When I weight bared on an affected limb, they told them just show us a one leg stance. So I shown them a one leg stance. And this was the gait after 1 month, just 1 month. There was peroneal palsy, but I cannot do anything for it. Yes, obviously, there is lateral instability. If I play a voice of video, some doctor has told, you will never walk, you have lateral instability. I have explained that patient that you don't have lateral instability. Actually, he have. Otherwise, he have lost the faith and run away. So, when things get complicated, it gets complicated in much ways. On the 35th day, I had discharged that patient on 10-15 days, but on the 35th day, he came back with a cellulitis, extensive cellulitis of my graft, from where I have isolated that fibula. And though there remained a discharging sinus, but it all healed in a week. And after 2 months, when he came back to me with a follow-up, this was the X-ray picture. Now we can clearly see the union on K wires. As those previous screws were discharging, I have removed it out, and this patient is doing excellent. He has a lateral instability. He has foot drop, but he is running his life, and he is able to do day-to-day active life. Actually, the thing is, those patients would recover. I asked, I was coming before, I wanted the video, but he didn't came back even after calling much time. But you can see his gait on this walker. This is not partial weight bearing, it's almost full weight bearing. So, inference is vascular bone grafts heal very faster. Oh, sorry. This is final and last slide. You can see how that fibula has been swollen up and that has been merged with lateral condyle. See, this patient will, any point of time, this patient has to go towards the TKR, total knee replacement. But whatever time we can delay, it's a 20-year of chap. So whatever time we can delay his TKR, we have to do that. And this is almost united limb, and at a young age, is most of the weight bearing line is inside the medial condyle. So I think that this patient will run peacefully and without pain for at least 15 to 20 years. Any difference of opinion, sir? Pranav sir or Amin sir?
Yeah, there seems to be a good healing. Our only concern is that first thing, infection, which may come up anytime. And second thing is whether you can do something for his instability and peroneal nerve palsy. So a reconstructive surgery at the ankle and a reconstructive surgery, Ashay ki Kapure ne bola hi na, kari shakaye.
I had planned and I had informed him for a two-tail this tibialis posterior transfer. But the thing is, patient is not coming back for even follow-up. So I have planned that. I had asked some of my eminent microsurgeon, my friend over Rohtak. He told me that I can do vascular TFL for lateral instability. Because all the things, no one arthroscopic person is going to go in, prefers to go inside this. So we can, in a company, can do that vascular TFL transfer also, but the patient is not returning. Mostly when the patients are happy, they don't come back. The thing. A second case, this patient has a bilateral femur fracture. One united and one came back with this bent knee. And the same vascular bone graft I applied, I prefer to do pedicle medial femoral vascular bone graft in this. It was fixed with K wire. Exchange nailing was done, and at the end of 3 months it united. And you can see the level of callus. It's a 3 months of callus. Same, I have compared the callus of his opposite limb. That's a fracture of 9 months. And this fracture has been united in 3 months. Both the side, in a AP and lateral, you can compare in a same patient. Moreover, a hand case. The patient has indulged his fingers in the thresher and almost everything is lost. And the patient is reluctant to undergo the abdominal flap. It's his own choices. There is scientific base of this case that abdominal flap would have not done that better. What my option has done, I have done an ALT for him, free ALT, free anterolateral thigh flap. The scientific basis is, with the chunk of tissues, I have also isolated that fasciolata graft, by which I will repair that extensor apparatus that has been totally lost. You can see almost the little and the index finger has been lost, and the middle second and third finger also even the extensor apparatus is lost. So we taken that fasciolata with this ALT. We had planned lot many things for him. Sorry. But nature recovered very fast than us. In a second stage, we have planned that we will shoe that extensor apparatus with that fasciolata. Then we will divide the fingers. So he will have a flexion and an extension. But just with a slipping that fasciolata below the skin, that fasciolata already adhered to that extensor apparatus, and this was the movement at the end of 1.5 months. Not a tip has been amputated. Not a tip from these cases, his fingers has been amputated. Later on, we divided easily, and these are the movements. Please play the video one. Second video, please. He is using different fingers every time. Third video, please. Tendon has not been repaired, but as the fascial data was immediately on the extensor tendons, it got adhered to it. And we separated fingers with like everything in en masse. We separated in a sequence. Actually, the thing was, the patient's demand was, okay, I will run with these fingers. I don't have any problem. I will run with syndactyly. But then again, he has to get engaged. And then the need again arises that now, sir, please separate this. The patient came after 2 years, and then we taken a video from him. So, I am employing the same things in avascular necrosis of hip. That is stage 1 and 2. Different bone grafts are there. In a stage 1 and 2, and it's a complete amelioration of the disease. In a stage 1 and 2, it's a microvascular fibular bone graft. In stage and 3, there are a variety of peri-hip vascular bone grafts. The thing in a 3 and a 4 is there is an articular collapse, and we cannot bring that articular surfaces by fibula, because fibula we are inserting from a lateral side. Vascular fibula we are inserting from a lateral side of a hip. Right? So, we cannot recover that vascular collapse from that microvascular fibular bone graft. So, I again go to the literature, and I came across the literature of Dr. D.V. Zhao, who employs the peri-hip vascular bone graft, because at the ASIS you have got vascular bone graft that is same like articular surfaces. It's not like, but it's a like. Same way we have got iliac crest based on DCIA artery. That is also a like vascular bone graft. And I have also evidence of these cases also. But as I have been told to cut short in a 5 minutes, obviously it's a 15-20 minutes. But if I will put a further, then it will go on a like hour. So methodologies I have not shown. May I be shown in next AOCB or any conference. But it works like a miracle. If in 3 and 4, my surgeries in AV and hip, if not a completely curing procedure, then they are the good delaying procedures. The patient may get a time of at least 10 to 15 years with his natural movements, and then he can go for a THL. So, these are employed, the same vascular bone grafts are employed in avian hip till early stage 4, avian scaphoid, avian flat bone, non-union neck femur. When non-union neck femur comes to me, I in a one go do 2 things. I strongly believe in a valgus osteotomy. When it comes to me, at the time where I was not well versed with all this bone graft, I was doing just valgus osteotomy and I was getting good result. But I used angle blade with that. Later on, with one go, I do a valgus osteotomy, angle blade, and then one of the vascular bone graft, peri-hip vascular bone graft. So till this thing, I have. You can say there is evidence for non-union of any bone and radiological non-union. I have evidence till decalcitrant non-union of any bone. Later on, I intended to do these things, but it will depend on the case availability as I am in my initial practice. So, it can be employed in radiological non-unions, it can be employed in Perthes, it can be employed in knee osteonecrosis, and it can be applied for a variety of cancer reconstruction, and it can be employed in spinal vertebral loss because of neoplasm, or it may be an infection. But for that I need to learn the spine again, and especially for a donor arteries I need to learn that anterior approach and all that. That may be or may not be possible in this life. So I am ending my lecture with inference. New modality of vascular bone graft, even work with wicker fixation. If you are good at microsurgery, fixation mistakes are forgiving. You can decide, when you decide to handle a complex trauma or a complication, you should have a basic. It should be proper knowledge of coverages, but it should have, you at least should have a basic knowledge of coverages. Plastic surgery is a whole, is a problem solving branch, and a good microsurgeon can pull you out of anything. Many things we are not knowing because we are not referring the patients to them, where we get many of the complex problems. Or the plasticos, those are surviving on a simple interpolational or you can say this translational flaps. Those are not telling that please refer to some microsurgeon and you will get answers for this. Because if we have to deal with such like traumas, we should have a